All right, let's talk about cardiovascular. So a lot of people think the cardiovascular is the hardest and it is often the lowest scoring test, but it doesn't have to be that way. Cardiovascular is actually quite easy. There's just a few small disease processes you got to learn and you're all cool. So the first thing is overall cardiovascular physiology. We'll talk a little bit about that. But then you're really primarily looking at high blood pressure and then atherosclerosis, which is going to be manifested in the heart as coronary artery disease. And then you're looking at dysrhythmias and heart failure. And that's it.
And there's only 20,000 lectures on it.
That's all you got to know.
Yeah.
So, on that note, let's get started with some overall cardiovascular physiology. Now, what is the ultimate purpose of the heart?
To pump blood.
To pump blood. So, we're going to have our heart in the middle here, and its purpose is to pump blood. So, got blood over here. Now, where does it pump that blood through? Arteries and veins. So then we have blood vessels. Now, in terms of the blood, what is the main component of blood? Plasma, water. What's in charge of water? What is in charge of water in your body?
Pressure system?
What's in charge of water? What's in charge of getting rid of it?
The renal kidneys.
Okay, what's the fancy word for renal? Or I guess not so fancy word for renal. Kidneys! Right, so when we talk about the blood, we're primarily talking about blood volume, and that blood volume is determined ultimately by the kidneys. So, kidneys are under the control of what hormones?
Aldosterone.
All right, so we've got aldosterone. We've got ADH. What else? If you remember way back into Pathopharm 1, fluid and electrolytes, we talked about natriuretic peptides. And there's 3 of them, A&P, BNP, and CNP. The most active one is BNP, which is produced by the ventricles. So these 3 things together kind of determine the amount of water that your kidneys are going to be holding on to. So ADH says hold on to water. Aldosterone says hold on to water. Natriuretic peptide says get rid of water. And then the kidneys also have their own mechanisms for regulating blood pressure and blood flow. And what mechanism is that? You got nothing, huh?
Is it like a hormone?
It's a pathway. It's a series of enzymatic actions that ultimately end in a hormone. Okay, it's called the renin, angiotensin, aldosterone pathway. Oh yeah, I knew that. Duh. Why didn't you say so? Okay, all right, I got it. So, what is the top of the renin, angiotensin, aldosterone pathway? Right, it's angiotensinogen. Angiogen. Okay. Angiotensinogen. So ogen is going to become whatever is before the ogen. So angiotensinogen becomes angiotensin. So angiotensinogen is produced by your liver floating around in your blood waiting to be activated. And when it gets activated, what activates it? Renin or renin? What's the right way to say it?
Renin.
Heck if I know. So, renin is an enzyme that is going to turn angiotensinogen into angiotensin 1. Now, what releases renin? The renals? Okay, so what releases renin? The kidneys. So when the kidneys feel like they don't have enough blood flow, they secrete renin, which gets this cascade going. Now, angiotensin 1 is going to be converted into angiotensin 2 by an enzyme conveniently named angiotensin converting enzyme, or ACE for short. Angiotensin 2, in turn, has a number of effects. There's several types of receptors. The main two types are type 1 and type 2. AT1 receptors are type 1, AT2 are type 2. Most of the blood pressure effects occur with type 1, and that's where we're going to focus. We're not really going to talk about the effects on type 2 in this course, although I believe they are in your slides. So, type 1, the major two effects are going to be, number 1, vasoconstriction. In fact, angiotensin 2 is the most potent vasoconstrictor that we know of. Second thing it's going to do is it's going to increase the secretion of aldosterone. What is that going to do? Okay, so it's going to lead to more sodium potassium pumps, so we're going to retain water and sodium. What's that going to do to blood pressure over time? Help to increase it. Aldosterone has another effect, and that is to increase smooth muscle cells in the arteries.
Wait, so it increases the sodium potassium pumps to get more water?
Mm-hmm. Retain water. Remember, the purpose of the sodium potassium pump is to pump sodium from the urine back into the bloodstream, and as that occurs, water follows and stays in the bloodstream. So the two main effects of aldosterone being high chronically is 1, more water retention, which increases blood pressure, and number 2, smooth muscle cell proliferation of the arteries. Okay. So, also there's another effect of ACE. Get a little arrow the other direction. Is a substance called bradykinin. I don't have enough room to write it. Bradykinin is a vasodilator. It goes right here. And ACE breaks bradykinin. So bradykinin is a dilator. Angiotensin 2 is a constrictor. ACE breaks the dilator and produces the constrictor. Does that make sense? So what is the overall effect of ACE? Vasoconstriction. So on the one hand, it inhibits a vasodilator. That's going to cause constriction. On the other hand, it produces a vasoconstrictor. That's going to cause constriction. So it's a double constrictor. And then, through the aldosterone effects, also influences the amount of blood volume and the number of muscle cells in arteries.
Wait, can you repeat that whole thing again? Wait, bradykinin is a vasodilator.
Yes.
And then ACE
Breaks it.
ACE breaks it. Okay, thank you.
ACE breaks bradykinin.
So, bradykinin is a vasodilator. ACE breaks it, so it becomes inactive. So by breaking the dilator, you shift things towards vasoconstriction. But that's not enough. We're also going to take ACE and use it to produce angiotensin 2, which is a direct vasoconstrictor. So ACE has two functions when it comes to constriction. One is to inhibit dilation, the other is to cause constriction. And then through the aldosterone effects of angiotensin II, you also end up with increased blood volume and increased number of muscle cells in arteries. So the kidneys do a lot in terms of the regulation of blood flow. Now, what's the number one driving factor behind the release of renin?
If they're not getting enough blood flow.
If the kidneys don't think they're getting enough blood flow. So they don't care about any other organ. All they care about is themselves. They're very selfish. But it helps keep the rest of the body alive. Now, one of the problems is if you have a problem with renal blood flow, like say renal artery stenosis, what are the kidneys going to do to compensate for renal artery stenosis?
Increase bradykinin.
They're going to increase renin. So they will sacrifice the blood pressure of the entire body. They're going to raise the entire body's blood pressure just to make sure that they get enough blood flow. Does that make sense? Mm-hmm. They're a little selfish that way. But on the other hand, if you inhibit that pathway suddenly, what happens in a patient with renal artery stenosis is they go into acute renal failure. That's actually, before we had modern imaging techniques, that was the way that we actually tested to see if you had renal artery stenosis. We would give a drug that blocked ACE that had a very short half-life, and if you went into renal failure, then we knew that you had renal artery stenosis. Nowadays, we just do an MRA. Just. Yeah. Does that make sense? So, we have the kidney, which ultimately is in charge of blood volume. And then the kidney also produces renin, which gets the angiotensin-aldosterone cascade going, which in turn affects the kidney through aldosterone and also affects the blood vessels. So now the blood vessels have two major things that can happen. They can get bigger or smaller, right? So, how many of you have ever gone snorkeling? Is it easy to breathe through a snorkel? No? Why not? The answer is yes, it's easy. It is. It's stressful. Okay, well, here's two other things to think about. Now, how big is a snorkel in terms of diameter? It's about like that big. Now, imagine if you were trying to snorkel through a straw. Would it be easier or harder?
Harder.
Why?
The volume.
Because it's smaller. So the smaller whatever tube you're trying to breathe through, the harder it is to breathe, right? Mm-hmm. Well, the same thing goes with blood vessels. The smaller the vessel, the more pressure it takes to push blood through it. So when we vasoconstrict, what happens to blood pressure? It goes up. The other thing is that how long is a snorkel? So imagine if you had an 8-foot tube that you were trying to snorkel through. Would it be easier or harder to breathe through that? Harder, why? Because it's longer and you got to push more air in and out, right? So the longer the tube, the more pressure it takes. So taller people typically are going to have slightly higher blood pressures than people who are shorter. Why is that? Because it takes more pressure to push blood through those longer tubes. Now, we don't really affect the length of the tubes very much physiologically, other than growing taller. So for the most part, the main factor is going to be the size of the artery. So what are some things that can cause vasodilation? Cause the artery to get bigger and thereby cause the blood pressure to go down.
Like drugs or like parasympathetic?
We're not talking drugs, we're just talking physiologically speaking.
Injury to the body, inflammation.
Okay, so inflammation can cause local dilation. Right? So some things that would cause that include histamine and tumor necrosis factor alpha. Does that sound familiar? Yeah. Okay. What else can cause vasodilation? Maybe something we learned about, 30 seconds ago? Okay, more like 2 minutes.
Brady.
Bradykinin? Yeah, so bradykinin can cause vasodilation. And then there's one other thing that we need to mention, which is called nitric oxide. Nitric oxide is actually produced by the endothelial cells, which are the inner layer of the artery. How many layers are there to an artery? 3. What are they? Ooh, tunica, big word. The tunica interna, media, and externa. Those are the newer ways of saying it. What's the old way of saying it? I don't know. We're new. You can also say it the tunica adventitia and the tunica intima instead of externa and interna. So the intima is intima with the blood. Get it? So it's touching the blood. So the tunica interna or tunica intima is actually made of one single cell layer. And what are those cells called? Endothelial cells. And the endothelial cells collectively make up the endothelium. So endothelial cells actually produce nitric oxide, which then travels right here to the muscle cells underneath and cause it to vasodilate. In order to vasodilate, what does a muscle cell have to do? Relax, or another way of saying it is not contract. Okay, so the blood vessel itself constricts, but the muscle cell contracts. So, what does nitric oxide do to smooth muscles? Cells. Cause them to not contract, thereby relaxing, and the artery can get bigger. So the discovery of nitric oxide was like a huge, major breakthrough in terms of the scientific understanding of arteries and how they work and all that kind of stuff. In order to have healthy arteries, you need a healthy endothelium, which can produce nitric oxide. When you lose that, that's when you start to get inflammation and atherosclerosis, which we'll talk about a little bit later. So, what things do we know that can cause vasoconstriction? Sympathetic response through what mechanism?
What do you mean?
Well, tell me the story. You sympathet, and then what happens?
All your energy stores are like going to the same place to get you ready to like fight or flight.
Oh, okay, but we're talking about arteries here.
Yeah, so your vasals are constricting to get the blood to the areas that need the most energy.
But why? How? So I go boo really loud, and you go ah. What happened?
Your body reacted
How do you sympathet in the first place?
when you're scared.
When you scared what? Why? How is it stimulated? I don't know. When you guys see this video, you're going to be really sad.
I already feel sad, so.
Hormone. Oh, really? Which one? Oh, epinephrine, norepinephrine. What do those do?
Oh, I thought that was.
Yeah, I told you you guys are going to be mad at yourselves. So, epinephrine and norepinephrine are released. They float around and activate what?
Vasoconstriction.
Yeah, okay, sympathetic response. And they do cause vasoconstriction. How?
With the receptors.
What receptors?
Alpha 1 and beta 1. No.
Stop while your head.
Alpha 1?
Alpha 1. Okay, so by stimulating alpha 1, we produce
Sympathetic response.
vasoconstriction. So, man, that's hard. It's like you've spent all summer long unlearning Pathopharm 1. No.
When we started Patho 1, you guys are going to get more dumb as like the years go on. And you're going to say, we never learned that.
No. The more dumb is your thought processes, not you're forgetting the material. The more dumb is when you forget things that are easy you should already know.
Like this.
No. Like, what color is the grass? Well, it can't be green. That's what I mean by nursing school makes you dumber. Not that you should forget the very first most important things, which are sympathetic response and inflammation. Yeah. Anyway, so alpha-1 receptors, when they're stimulated, cause. And what are the two natural things that stimulate alpha-1? Norepinephrine and epinephrine. And then also dopamine, except your body doesn't produce enough dopamine by itself, so really only when you give it as a drug. Okay, that's fine. What other substances do you know of that can cause vasoconstriction? Angiotensin 2. Isn't that so convenient that we just learned it? Okay, so in terms of controlling blood flow, so far, we started with the kidney, which controls blood volume, but it's under the control of some hormones. We name those hormones. And then we talked about the kidneys release renin, which causes renin-angiotensin-aldosterone pathway, which in turn causes the kidneys to produce more or retain more blood volume, but it also causes vasoconstriction. And it also causes aldosterone, which is going to increase the amount of smooth muscle cell, which is going to create more tone on the artery. So it's going to increase blood pressure over time. Does that make sense? Mm-hmm. Okay. Now, what is generating all this pressure to begin with? What generates blood pressure?
The kidney.
Say again? The contraction of what? The heart. Really? Huh. I thought it was the kidneys. Okay, so yes, it is the heart. So the heart is going to pump blood. That is what ultimately generates the pressure. Now, the larger your arteries, the less pressure your heart has to generate. And the lower the blood pressure will be. The smaller the arteries, the more pressure your heart will have to generate, and the higher the pressure will be. The more blood volume is also going to play a factor. So we're going to talk about how that works. Now, before your heart can pump, what does it have to do? Okay, put your hands in the shape of a heart. Now, show me how your heart pumps. Okay. So what's it doing? What's it doing? Contracting and relaxing. What happens when it relaxes?
Blood goes in.
It fills up. So in order for your heart to pump blood, it must first fill up. So your heart's got to fill up with blood, and then what'll happen? And then it'll contract, and that will push the blood out. So it is a two-phase pump. Relax, contract, relax, contract. So what is the relaxation phase called? Diastole. What is the pumping phase called? Systole. Okay, this is like basic A&P stuff. You guys all promised me you would remember this stuff. Now you're lying. All right, so we divide the heart up into 4 chambers. So what is the top left chamber?
Right atrium.
Yeah, that's actually the right atrium. Then the right ventricle.
Left atrium. Left ventricle.
Okay, so blood's going to come in at the top and then go down to the ventricles, right?
Right.
So it's going to come in from the top and then down to the ventricles, right? Right?
Yes.
Right. Okay, so what is it that drives blood into the heart during diastole? Where does that blood come from? The veins. And what is it that is pushing the blood back up?
Oh, your skeletal. No.
Random motions and valves. There's very little pressure, right? Okay. But when it opens up, it kind of creates a little bit of a negative pressure, which also helps to suck the blood in. Okay. So blood is going to start out in the atrium, and a large amount of it is going to just pass through. That's called rapid filling. You probably remember that from health assessment. Then right before the ventricles are about to go, what do the atria do? They contract. What's that called? is called pre-systole, and it's also known as atrial kick. And I don't really have enough room here, but I'm supposed to kick at this point in time. Let's see if we can arrange for that. So, it's atrial kick. Move these chairs out of the way. Here, you take my Coke.
Oh, okay.
Oh no.
So, it's atrial kick. Gotta do that soft so I don't break things. But the whole idea is that the atria are kicking the blood down into the ventricles. And what's the fancy name for that? Pre-systole. What's the cool name for that? Atrial kick. Okay. So about 25 to 30% of the blood in the ventricle right before systole is from that atrial kick. So what happens if the atria start doing this? What's that called? Atrial fibrillation. So in atrial fibrillation, you lose that atrial kick, right? So how much of the blood in here do you lose then? 25 to 30%. Is that big? Yeah, that's pretty big, right? Because if the blood isn't in the ventricle, it can't get pumped to the rest of the body.
Does it ever make it to the ventricle? Like next time around?
Next time around, but just less volume is in the ventricle altogether. So let's say that ordinarily there's 100 milliliters in the ventricle. How much would there be if you lose 25% of that? Maybe 75. Okay, so the amount of blood in the ventricle right before you have systole is called end diastolic volume.
Oh.
So, the amount of blood right before you pump, what's the fancy name for pump? Systole. So right before systole, you have the end of diastole. And that blood volume is called end diastolic volume, EDV. And there's another fancy name for that, which is preload. So, the reason it's called preload is because it actually stretches the muscle fibers of the heart ever so slightly. Now, the ventricles begin to pump. What influences how strongly they pump? Two major things. One of them you should already know.
The ED?
How?
Because it's stretching it. So
Okay, so as it stretches, it's going to make the muscles contract a little bit harder. I like to think of this as the bra strap principle. So it's kind of like elastic, right? So the more you stretch the elastic, the harder it snaps.
yeah.
But if you overstretch elastic, what happens?
It breaks.
Yeah, it breaks down. So this is reflected in a little graph where if you take end diastolic volume and you plot it over what's called ejection fraction, which is a measure of contractility, what you'll see is that as you increase the end diastolic volume, you increase contractility up to a point, and then it starts to go down again. And this is called the Frankstarling law of the heart. So what does the Frankstarling law of the heart say?
As you increase EDV, it will increase contractility to a certain point.
As you increase end diastolic volume, you're going to increase contractility up to a point. So Frankstarling law of the heart is one mechanism for increasing contractility. Name one other.
The amount of blood.
No, that's end diastolic volume. Name another one. You learned it in Pathopharm 1. And we talked about it just ever so recently in treating shock. Name another mechanism for increasing the contractility of the heart. Do you want me to scare you?
Epinephrine.
Okay, epinephrine, norepinephrine, but what do they do?
Oh, the alpha 1.
Well, that's alpha 1, vasoconstriction, that's not the heart.
Oh.
Beta 1, are you sure?
Oh,
Yeah.
oh yeah, 'cause it's one heart.
Yeah, whispering the answer doesn't make you less right in this case. But not having constant confidence in your answer lost you brownie points. So sad. All right, so it's beta 1. When we stimulate beta 1, what are the 3 effects?
Oh, chromotropic.
Inotropic, chronotropic, dromotropic. So in terms of contractility, that would be inotropic. Oh, it's like Pathopharm. Almost never happened. No, it's like it was a bad dream. That's what it was. Okay, so in addition to the end diastolic volume, which is going to increase contractility through the Frankstarling law of the heart, we also have beta 1 stimulation by norepinephrine and epinephrine. So there are 2 mechanisms for increasing contractility. Now, for the bonus prize, what determines how much blood actually comes out of the heart? The ejection fraction. Well, let's not determine it, that's just a measure. What determines how much blood is going to come out of the heart? Well, it's actually complicated. First of all, how much blood is in there? Second of all, how much squeeze do we have? Third of all, how much resistance is there? So I'm going to borrow your water bottle here for just a moment. Yes, thank you. It's so lovely. Now, this thing is really full. There's lots of pressure in there. Okay, it's full and I'm squeezing it. How come nothing's coming out?
Resistance.
There's a cap? Oh, okay. So, what is the cap doing?
Stopping it.
It's stopping it. It's providing resistance. So, the 3 things that determine how much blood comes out of the heart, first of all, the end diastolic volume, the preload. Second, the contractility, which is trying to squeeze it out. And then third is the resistance. What is causing the resistance?
The valves.
Okay, which valves? The semilunar valves? What are those 2 semilunar valves called?
Yeah.
Say again? The aortic and pulmonic valves. So, blood is trying to come out those, but what's on the other side of those valves? Okay, arteries. And what's inside those arteries? Blood. That's under pressure. And that pressure is holding the valves shut. So your heart has to pump harder than the pressure holding it shut. Does that make sense? Yeah.
Forget it though.
So let me draw this just ever so slightly larger now. So let's just imagine your pulmonic, well, let's do the aortic. So, kind of like that. So, here's your aortic valve, and here is aortic valve right here. So you've got blood inside here pushing down, holding your aortic valve shut, right? Yeah. Okay. That is called afterload, yes. So resistance is known as afterload. And you've got blood pushing the valve down, holding it closed. In order to overcome that pressure, the heart has to generate enough force to do that. So what pressure represents afterload? Say again? No. Are you just guessing?
No.
I'm just saying every word that comes to my mind, and hopefully one of them will be right. It's multiple guess. Well, Rebecca did say one of the right answers. But which one of them is right?
Diastolic.
Why would make you say diastolic?
Because you asked her, like, if she was sure about it. So that's why.
So you don't know. You're just trying to use psychological reasons to figure it out?
Is it because you build up pressure during diastole?
Okay. So,
Wait, no.
Isn't it because
what's happening during diastole?
it's relaxed?
The heart is relaxed and filling.
Yeah.
So whatever pressure is there is not generated by the heart at that moment in time. It's generated by the arteries and the amount of blood.
Yeah.
Now, when the heart pumps, it's got to overcome that diastolic pressure. Does that make sense? Now, that understanding led to a wrong theory. And the wrong theory was that you want to have a good high pressure, that means your heart is really strong. So the higher your pressure, stronger your heart, a more vigorous heart. Now that's good, right? But that's actually not very good. Here, I'll let you give that back. You don't actually want the heart to have to work too hard for a number of reasons we'll talk about later. But what you want is for the heart to have an easy time to pump. So the diastolic pressure shouldn't be too high, because that can cause problems. But you want it high enough. We'll talk about what happens if it's not high enough later. So as the heart squeezes, you've got the interaction of how much blood was in it, how strong is it squeezing, and how much resistance is there. And the interaction of those three things are going to determine how much blood comes out. Does that make sense? Okay, now we can represent that mathematically by an equation. Are you ready for it? Mm-hmm. Okay, so cardiac output, CO. Oh man, I hate this. Cardiac output equals the heart rate times the stroke volume. What is stroke volume? The amount of blood that comes out every time your heart pumps. So each pump is called a stroke. And then how many times is it stroking in 1 minute? And that will give us the cardiac output in liters per minute. What is the average cardiac output? It's about 5 liters per minute. Okay, at rest. So when you're like running around and stuff, it can be much, much higher. So stroke volume in turn is determined by what? It's the end diastolic volume, also known as preload, times the ejection fraction. What is an ejection fraction? So what we do is you measure how much blood is in the ventricle before contraction, end of diastole, and then you measure how much blood is in the ventricle at the end of systole. And that ratio is called ejection fraction. Now, your heart is not super efficient. On average, it's going to pump about 65 to 70% of blood that's in it. So an ejection fraction of 65 to 70% would be considered normal. So in fact, your heart's really inefficient. But one of the measurements of efficiency of the ability to squeeze blood out is called, it's called ejection fraction. So if ejection fraction is low, that's a sign that your heart is not pumping out enough blood. Does that make sense? All right, now all of this so far assumes that something is doing its job properly. And what is that something?
The heart.
Oh, okay, yes, the heart. But where's the blood going through?
The vessel?
In the heart. Where's the blood going through? It's going through some little, okay, and separating the chambers. Valves. Okay, so in our little model, the valves are being held back by blood pressure. But what if the valves are being closed, artificially closed? What's that called? Where they just don't open up enough. I don't know. What's it called when something doesn't open up enough? What's another name for that?
Shut.
If we were describing a renal artery, we would say stenosis. And so if you were talking about a valve, you would call it stenosis. So if the aortic valve is not opening up properly, that would be called aortic stenosis. So we are assuming that the semilunar valves are opening correctly. We are also assuming they close correctly during diastole. If they don't close properly during diastole, what happens? You get backflow, and so the pressure went out and then it wants to come right back in. So instead of pushing blood one direction only, the blood is kind of going in both directions at the same time. It's not very helpful. Now, to go from the atrium to the ventricles, where does it have to go through? Which valves? Which valves? The atrioventricular valves. On the right, it is the tricuspid, and on the left, it is the bicuspid, also known as the mitral. Okay, so, and we're assuming that those are opening and closing properly as well. So, if those don't open up, if they are stenotic, what happens? Not backflow.
Blood doesn't even get into the ventricle.
The blood just doesn't get into the ventricles in the first place. What's that going to do to our end diastolic volume? It's going to decrease end diastolic volume. Think about it. If blood can't get in the first place, it's going to decrease end diastolic volume. The opposite is regurgitation or prolapse, mitral valve prolapse, where it doesn't close all the way. And then what happens? When your heart pumps, some of the blood goes back into the atrium. And what's that going to do? What part of the cycle is that going to affect? Nope, not filling. The interaction of these three things is going to go backwards. It's going to go backwards instead of forwards. Because there's no resistance backwards. There should be a little wall there. The bicuspid should be like, oh, nope, can't go this way. But instead, it's right back up. Okay. So, in order for the heart to pump correctly, you have the interaction of preload contractility and resistance, or afterload. But you also have to assume that the valves are doing their job correctly. All right. Any question about the overall big picture of blood flow in the body?
Yeah, one question. When you drew that little thing on the vessel, is that supposed to be nitric oxide?
This little squiggle here? Okay, so this is actually supposed to represent the media layer.
Oh.
These are muscle cells. Yeah. Yeah. So that's meant to be muscle cells. All right. Any other questions? All right, we got about 45 minutes left, so let's see what we can do with that time, shall we? So, we're going to talk about blood pressure, and in particular, high blood pressure. But we are going to mention low blood pressure real quick like. We've already talked about shock in Pathopharm 1, so you should probably go back and review that. So what are the 5 types of shock? What is shock? There's a handy dandy little video on it, so you can watch that. In general, what is the treatment for low blood pressure?
Fluids.
Give fluids. If you have someone who has chronically low blood pressure, what could you do to help them retain their fluids? have the patient eat more salt. I know that's very unpopular these days with the American Heart Association because their whole big thing is we need to eat less salt. However, there are some people who have low blood pressure and faint all the time because their blood pressures are low, and they can drink all the water they want, but it just goes straight through them. So what do they need to do?
Eat more salt.
Increase their sodium.
When people faint, like sometimes I faint when I'm getting my blood taken. Is that because my blood pressure is down?
That seems to be more of a nervous reaction. Yeah. But I don't know personally. Okay, let's be quiet about that. You were like, is it okay? I don't want the camera to hear me.
Yeah.
Too late, I repeated the question. So, with low blood pressure, pretty simple overall. With high blood pressure, that is a little bit harder. So, the first thing is, what do we mean by high? So, for most of your lives, you probably learned that what is normal blood pressure? Yeah. Okay. So the powers that be, the American Heart Association / American College of Cardiology, in 2017, they changed their guidelines to be even stricter than before. They also changed some of the terminology. So if you're talking to people, or if you're listening to lectures that are older, the terminology is not 100% translatable. So just be aware of that. So less than 120/80 is going to be considered normal. And then the next one is elevated, which is going to be 120 to 129 over less than 80. So in terms of elevated, the only thing that can be elevated is the systolic. Does that make sense? If diastolic is ever higher than 80, that's going to be called stage 1 high blood pressure or hypertension. So that will be either blood pressure of 130 up to 140 or 80 to 89. Does that make sense? Now, in the old days, this was called pre-hypertension. And then when you actually got high blood pressure, they would call that stage 1. Now, stage 1 is what used to be called pre-hypertension. Now, the reason they made that shift is they wanted to underscore the importance that you're at risk for all the problems that high blood pressure can have, even at this stage. But when you called it pre-hypertension, it wasn't scary enough. So they used to call it high normal, but that wasn't scary enough, so we changed it to pre-hypertension. But that wasn't scary enough, so we renamed it to hypertension 1. Does that make sense? Mm-hmm. But what can be confusing is that in the older days, hypertension 1 meant you had high blood pressure that needed to be treated with a drug. Now, hypertension stage 1, we don't treat with drugs, just lifestyle. Unless the patient has another problem that would need blood pressure lowering. So for example, if you have a patient who's got diabetes, what can diabetes lead to is that can affect blood pressure? Kidney nephropathy. So because of that, they need to have their blood pressure lower than someone who's just has no other problems. So someone with diabetes or someone with, say, heart disease might need blood pressure to be lowered with drugs at stage 1. But the average, otherwise healthy person, do they need treatment with drugs at stage 1? No. Now, stage 2 is anything greater than 140 over greater than 90. And again, in the old days, we used to call that stage 1. And then once a person got up above 160 systolic, that we would call stage 2. So it's a little bit different now than it used to be.
Is it, sorry, excuse me, is there hypertensive crisis too, or did they not have
Say that again?
hypertensive crisis?
Yes, we still have hypertensive crisis, and we're about to mention that. So, once you get above 200, you end up with what, or 200 over 120, we end up with what's called hypertensive urgency. And if the patient has signs and symptoms, then it's crisis. So hypertensive urgency doesn't necessarily need emergency treatment, although it often is treated emergently. But hypertensive crisis always needs emergency treatment. Does that make sense? So what kinds of signs and symptoms could a person have? Headache, dizziness, nosebleeds, floaters in their eyes, double vision, anxiousness. So if they have symptoms, what do we call it? Hypertensive crisis. Now, the drug of choice, according to your book, is an old drug called nitroprusside. The brand name is Nipride.
For crisis?
For crisis, yes.
Even though it's an old drug, we still use it?
Well, it's not used as often as it used to be. So the newer thing to use, and we're going to actually go over this drug name a little bit later, so we're not going to mention it so much now. Actually, no, I need to tell you what it is now. Nitroprusside is a very old drug that is used to treat hypertensive crisis. The way that it works is by vasodilating arteries and veins. So it works really, really quickly, and it's given IV. Now, in today's environment, it's used less often, and more often nowadays, they're beginning to use a drug, it's a calcium channel blocker, and we'll talk about that particular drug name when we talk about calcium channel blockers next class. So, hypertensive crisis is just urgency plus symptoms. What kind of symptoms?
Headache, dizzy, nose bleeding.
Yeah. Signs and symptoms of high blood pressure. So, headache, dizziness, nosebleeds, vertigo, floaters in your eyes, double vision, all that kind of stuff. Blood in the urine, that'd be another one, for example. So all of those are potential signs and symptoms of high blood pressure. Now, that's crisis. Most patients are not going to be in crisis. They are going to be what we call in the silent killer phase. What does that mean? High blood pressure is the silent killer. It means you don't have symptoms. You don't, at least none that you recognize. So you don't have any signs or symptoms, but you're having damage being done over time. Now, what organs are being damaged by high blood pressure? These are sometimes called target organs. What does high blood pressure do to your organs? Which organs does it hurt? Okay, it hurts the heart. Now, if you want to make a muscle big, what do you do?
Work it out.
How would you work it out?
Lifting weights.
By lifting weights. What kind of weights? Big weights for high reps, right? Mm-hmm. So, when you make the heart pump against resistance, what happens to the heart muscle? It gets bigger and thicker. So imagine for a moment that you had your heart, and here's your left ventricle, and you made that ventricle muscle thicker. What did just happen to the chamber? It got smaller. What does that do to your end diastolic volume? It makes it lower. So when you have ventricular hypertrophy, what you do is you make it so that there can be less blood pumped. Your heart is now less efficient than it was before. Does that make sense? At the same time, what does muscle need? Muscle, does it use up a lot of energy or a little bit of energy? A lot. So what does it need? It needs more oxygen. So not only have we reduced the heart's ability to pump blood, we've also made it so that the heart itself needs more blood. So left ventricular hypertrophy is not a good thing. It leads to decreased cardiac output and a more vulnerable heart muscle. So the first thing was the heart. In an extreme form, it can actually lead to heart failure, which we'll talk about in a later class. What's the next thing that it can damage? The brain. The leading cause of stroke is high blood pressure. So high blood pressure directly can lead to stroke. What else? Well, let's not leave the head yet. Oh, the eyes. Why is he making crazy eyes at us? So sometimes you'll see that high blood pressure is leading cause of blindness. Sometimes you'll see diabetes as the leading cause of blindness. And sometimes you'll see macular degeneration as leading cause of blindness. No matter how you cut it, a leading cause of blindness is high blood pressure. All right, and then you guys said kidneys. And we already talked about that when we talked about chronic kidney disease. What are the two major contributing factors to chronic kidney disease? Oh, you didn't block it out that fast. What are the two major contributors to chronic kidney disease? Nope. Diseases that damage the kidney over time. Oh, one of them's high blood pressure. Right. What's the other one? Diabetes. Yeah. So can ultimately lead to kidney failure if untreated. And there's one more.
That it damages?
One more that it damages. Arteries. And here the major thing is it's going to lead to the development of atherosclerosis, which we will talk about next class. Don't you feel lucky? All right, atherosclerosis. So 1, 2, 3, 4, 5. 5 target organs that can be damaged by high blood pressure and what the damage ultimately results in. Any questions about those? Okay. High blood pressure is a disease of degree. And that's partly why they have the stage 1 and stage 2. They're saying that even though it's just a little bit high, you're still damaging things, but you're not going to damage them as much as someone who's higher. Someone with a blood pressure of 140 over 85 is not nearly as bad off in terms of long-term damage as someone whose blood pressure is 180 over 100. Does that make sense? Okay, so the higher your blood pressure, the more damage is being done. But even at relatively low blood pressures, you can still accumulate damage over time. So we need to, before we can treat high blood pressure, we have to distinguish some causes. And there's 2 major types of high blood pressure. The first one is called primary or essential. What that means is that there's no single identifiable cause of the high blood pressure. So if you recall back to our genetics lecture, what would it be called when there's multiple interactions of genetic and environmental variables? What? Is it what?
Multifactorial?
It is multifactorial, but this is not Jeopardy. So you did not get the answer correct. So multifactorial. High blood pressure is multifactorial. And when there's no single factor that can be isolated, we call it primary or essential. The second type of high blood pressure is called secondary. And that's going to be secondary to what? to an identifiable cause. So in your notes, I've given you this really long list of potential causes. So I'm just going to highlight a few of them here, but you need to be familiar with the list. You're not going to have to reproduce the list on your test, but you need to recognize that those conditions could cause high blood pressure and ideally know how they could. So for example, if you have bad kidneys, how could that lead to high blood pressure? By not getting rid of enough fluid, you retain fluid, and that leads to excess blood volume, high blood pressure. What if you had renal artery stenosis? What does that do?
Bless you.
What is renal artery stenosis? So it's when the renal artery is too small, the kidney can't get enough blood flow. So what does it do? It secretes renin, angiotensin, aldosterone, and that is going to in turn cause vasoconstriction and elevated blood volume. So what if a person has too much, has pheochromocytoma? What is a pheochromocytoma? Say again? Well, it's a tumor that secretes epinephrine. So that could cause elevated blood pressure. So you get the idea, right? Okay. So before we just treat a patient for high blood pressure, oh, you got high blood pressure. Here, take this high blood pressure medication. We need to rule out potential secondary causes. Does that make sense? So before a person gets treated for high blood pressure, they need to be screened for secondary causes. And we're going to do something like a basic metabolic panel, a urinalysis, and an ECG.
Screen for causes, you said?
Yep. That would be kind of like an at minimum what you should do or make sure is done for a patient. You are not going to be the ones ordering those as nurses, but you should be looking for them before you see, oh, yeah, they got high blood pressure. Let me tell you about high blood pressure and what you got to do about it. Take your drugs. Does that make sense? Because if you're treating it as though it's primary or essential, but there's an actual identifiable cause that you're ignoring, well, that's the stuff that kills people. No, it's not good at all. Okay. So there you go. Now, once and the other thing is that you don't just say, your blood pressure is like 140, you got stage 1 hypertension. What we're going to do is you're going to take their blood pressure today, and then we're going to have them come back a week later, and we're going to measure their blood pressure again, and we're going to make sure that it's high over time. We may also ask them to take their blood pressure at home and bring in those blood pressure scores as well. So you don't base hypertension on a single reading. Now, if that single reading is like, say, 180 over 98, yeah, you can be pretty safe to assume the patient's got high blood pressure. But when you're talking relatively high, just a little bit high, you really want to make sure that number one, you're doing a good resting blood pressure, and number two, that you've confirmed that high blood pressure through time. Does that make sense? Okay. Now, approach to treatment. The very first thing we want to do when we treat high blood pressure is we want to do the least invasive thing first. So what is the least invasive thing? It's actually the most invasive of all. TLC, which is not tender loving care. TLC stands for therapeutic lifestyle changes. We want you to change your entire life, and people think that's not invasive. So what are some therapeutic lifestyle changes a person could make that might reduce their blood pressure?
Their diet.
Okay, first thing is diet. All right, what dietary interventions could we do?
Lower sodium.
All right, lower sodium. Now, the American Heart Association has been on this really big anti-sodium kick lately. They want everyone in America to eat less than 1.8 grams of sodium per day, which is insanely low for the general population and probably unnecessary. And if you look at certain populations, like say if you look at Japan, they eat 4 to 5 times the amount of sodium that we do, and yet they have lower blood pressure than we do. So not everyone needs to lower their sodium level. But if you've got high blood pressure, it's worth lowering your sodium level and see what happens. If you respond to lowering your sodium, that's probably a good thing for you to continue to do. And generally speaking, Asian populations are the least responsive to sodium restriction, and black populations are the highest responders to it. But again, it's individual and your mileage may vary. So just because you belong to a particular ethnic group doesn't mean you shouldn't try it, but your chances that it will work for you are lower, if that makes any sense. What else?
Exercise.
No, still in diet.
How are we
Like
still on that?
fat, fried foods.
It's called the DASH diet. So what is the DASH diet? Have you ever heard of that? Okay, some of you are nodding and some of you are shaking. So for those of you who are nodding, what is the DASH diet? You don't remember. So it is lean meat and low fat and high vegetable.
How does that stand for that?
Oh, I don't know what DASH does not stand for any of those things. So sometimes this is known as the Mediterranean diet, which if you've ever met a Mediterranean person, that's not necessarily how they eat, but hey, whatevs.
Yeah.
So that's called the DASH diet. If you actually follow that diet, there is a very good chance that you will also do the next thing, which is reduce calories. Which brings us to something that is not necessarily diet, but is important, and that is lose weight. If a person is overweight or obese, they should probably consider losing weight if they have high blood pressure. As you guys know, I used to be a bit heavier, and when I was a bit heavier, my blood pressure was never really high, but it was, like 125 over 82, 84. We just go to the doctor and they just check it the way, not a real way. And then I started working out and lost weight, and now my blood pressure is like 116 over 72. So, okay. So in my case, decreasing calories was an enormous part of controlling blood pressure. Another thing you can do along that line is exercise. What kind of exercise does a person have to do?
Weightlifting. Weight-bearing exercise.
Any would be nice. Most people are sedentary. Even people who claim to be active are sedentary. If you work in an office and the most exercise you get is going outside to check your mail, or maybe on the weekends you go to the mall, you are sedentary. So making an effort to do some cardiovascular exercise would be nice, and it doesn't have to be a lot. Taking a 10-minute walk after dinner is far better than doing nothing. Taking a 30-minute walk after dinner might even be a little bit better. Adding in some resistance training on top of that would be fantastic as well. But what kind of exercise? Any. But ideally you're going to be doing 30 to 40 minutes every day of at least walking, and also some resistance exercise as well. In order for me to do my thing, again, I already mentioned this when we talked about diabetes, all I did was 3 strength workouts a week, about 30 to 40 minutes, and then I walked about an hour the other 4 days a week. So never ran, except once where I was like, well, we're not doing that again. So that was pretty much it. You don't even have to sweat unless you live in Florida. So exercise, what else you got?
Potassium and
Okay, what about potassium and calcium? Okay, so there is some evidence that suggests that sodium being high isn't necessarily a problem. It's the ratio of sodium to potassium intake. And the problem is that we just don't get enough potassium intake. What's the major way we get potassium?
Vegetables.
Vegetables. So that goes along with the DASH diet. All right, what other therapeutic lifestyle interventions do you think a person might want to consider?
Their sleep.
Smoking.
Smoking cessation. All right, what else? You guys mentioned sleep. That's probably a good one. But increasing sleep goes along with something else, decreasing something else in your life.
Stress.
Decreasing stress. So stress management techniques are important. For some patients, just learning how to relax and let go of things can make a tremendous difference in their lives. All right, so here we have a variety of therapeutic lifestyle interventions. And before we start a patient on drugs, patients should do these things. Now, if a person's got a blood pressure of 180, doing these things is not going to be enough in and of itself, at least not at first. But we can't ignore those things. Does that make sense? So, as an example, when I was working as a nurse practitioner, there was a guy who came in. His blood pressure, I think, was about like 148 over 96. So not high, but a little bit high. And it turned out that he was working at the hospital. They had like a food court. And so he was working at one of the food court locations. And he was the manager. Well, very stressful job, number one. But they got unlimited soda. And he'd gained like 30 pounds since he started working there. So, change your soda to diet soda, get a little bit more exercise, and stop eating the food that you make. And all of a sudden, his blood pressure went back down because his weight went back down. So you don't want to just assume, here, take these drugs. One of the biggest problems that we have in the United States is people just expect a drug to solve the problem. And without doing these things, the drugs might not solve the problem. Now, for some patients, even with therapeutic therapeutic lifestyle changes, they're still going to need medications. There's other patients who will need a combination of both. But if you don't do the lifestyle modifications, the drugs will not work as well. Does that make sense? So we want to make patients feel like they are a part of their medical plan. It needs to be their plan. It's their life. And taking a drug, a lot of times, just isn't enough. Most patients are not going to be controlled on even 2 drugs. So doing everything they can do to help bring their blood pressure into control is going to be helpful. The more that they understand this is not just a number that needs to be treated. This is a condition as a result of my lifestyle. Then what's the change? What's the narrative then? I need to change my lifestyle. Does that make sense? Okay, we are going to talk about drugs next class because I see we are out of time and you guys are putting stuff away. All right, so let's do a quick recap on blood pressure. So just a reminder, there's 3 major components of blood pressure. The first component is the heart, which generates the pressure in the first place. The second is the blood, which is being pumped throughout the body, and it's the volume is the primary driver of blood pressure there. And then we have the arteries, or the pipes, through which the blood flows. So, the 2 determinants of blood pressure when it comes to arteries is the length of the artery, which is typically fixed in a person who's no longer growing. And then, more importantly, is the diameter, which can either constrict or dilate under certain hormones and other influences. So, real quick, let's go through what influences each of those things. So, with the heart, the major components of blood pressure in the heart is number 1, cardiac output. Cardiac output, in turn, is going to be determined by the amount of blood coming into the heart during diastole. So the two components of that are rapid filling and then atrial kick.
And that's what determines cardiac output.
That determines preload, end diastolic volume. So first you have to fill the heart up with blood. And what's the fancy word for that? End diastolic volume, EDV, or preload. Then you have contractility, which is the amount of force that's exerted by the heart muscle. And there's two components of that, or two influencers of that. One is sympathetic response. So beta 1 stimulation is going to increase contractility. The other thing that influences contractility is the degree of stretch on the heart fibers, the heart muscle fibers. So that is going to be reflected by end diastolic volume. So as end diastolic volume increases, stretching the heart, that's going to cause an increase in contractility. And that is known as the Frankstarling law of the heart. The degree of stretch. Now, those two factors, your end diastolic volume combined with your contractility, then have to interact with the resistance that is holding the valves closed. So it's got to overcome the resistance of the blood on the other side of the aortic and the pulmonic valves. Now, on the pulmonic side, most of the time that's a relatively low pressure system. It's not that big a deal. On the systemic side, it can be pretty high, especially with a patient who's got high blood pressure. So in order to pump blood out of the heart, your heart has to generate enough pressure to overcome that resistance holding it closed. And what's that resistance holding it closed called? Holding the aortic valve closed. Afterload. So preload is volume of blood inside the ventricle. Contractility, the degree of force, and then afterload is the pressure, the blood pressure, holding the valve closed. One more time, with feeling. Preload is also called end diastolic volume. It is the volume of blood inside the ventricle right before the ventricle contracts. Contractility has two components. One is sympathetic response, the other is Frankstarling law of the heart. The more we stretch the ventricles, the harder they will contract. I'm not adding any new information. Your mind should not be blown. We spent like 45 minutes on this last class, so it's just a quick recap. So, your end diastolic volume and your contractility together are going to influence how much blood comes out of the heart, but it has to work against the pressure on the other side of the aortic valve holding the valve closed. What is that pressure called or referred to? Afterload. So your heart's generating pressure trying to push blood out. The pressure on the other side of the aortic valve is holding that valve closed, trying to prevent the blood from coming out. So it's got to overcome that. Now, there's one last thing that we didn't mention last time that I need to mention, which is that imagine for a moment that you had a pump right here. And you've got this just big, long tube. Now, if you're going to pump blood, a certain amount of blood, into this tube, what do you have to do to all of the other blood in the tube? You got to push it all the way down. So the longer this tube is, the more pressure the heart has to pump, right? That's not how our heart works. The reason why is the aorta is stretchy. So when your heart pumps, you don't have to push every little bit of blood throughout the entire body at that exact moment in time. You really just have to pump blood against the amount of blood in the aorta itself. So remember, the aorta is shaped kind of like this. So you're only pumping blood against this little part of the body because the aorta is going to stretch to accommodate that extra blood. Then, after the aortic valve closes, then the aorta is going to kind of like shrink back down. And then that will push the blood through the rest of the body. Does that make sense? So, the aorta being able to stretch does two things for us. One, it decreases the amount of systolic pressure the heart has to generate. The second is that it increases diastolic pressure. And that's really important for the heart for one very important reason. Now, how many of you guys have ever seen the movie The Illusionist? Okay, in The Illusionist, he does this one little trick where he says, okay, what I want you to do, I'm going to close my eyes, and what I want you to do is take a fist, hold up to your head, think very hard, and then put your hands together, and he guesses which hand the person had up to their head. Do you remember what the trick was? No. Well, the trick is that when you do this, and you put your hands together, this one was kind of pale because it had the blood pushed out of it, whereas this one wasn't. So what does the heart do? What's it doing? What happens to the color of my palm every time I squeeze and then open again? Pale, pink. Pale, pink. Why?
Because blood is coming over.
When I'm putting pressure, what's happening to the blood? It's being pushed out. What is your heart doing?
Pushing it out. Pushing it out.
Now, in order to feed the heart muscle, you've got to have coronary arteries going through the muscle. When your heart squeezes, is the heart muscle being perfused with blood? No. So it can only be nourished. It can only receive blood supply when the heart is relaxed. So this unique structure of the aorta that lets it stretch, so it reduces the amount of squeeze needed, but it also increases the pressure during diastole, which pushes blood into the heart, into the coronary arteries, and allowing it to perfuse. Does that make sense? In elderly patients, they actually lose the stretch of the aorta. The aorta becomes more stiff like a hose. So what happens in elderly patients is their heart has to generate more pressure. What does that do to systolic pressure? Makes it go up. And then they also have less diastolic pressure. So it's common in an elderly person to see a blood pressure of maybe like 150/70. And that is actually more dangerous for a person than just having regular high blood pressure where they're both high. Because now they have less perfusion of the heart during diastole. So anyway, that's called isolated systolic hypertension, and it is more common in elderly folks. I've got a little presentation on YouTube that I will link to if you're interested in more about that subject.
But that doesn't affect cardiac output, right?
Say that again. Isolated what?
Isolated systolic hypertension. Does it affect cardiac output? Yes, it lowers cardiac output. Or it increases the work of the heart to get the same amount of cardiac output, which in turn makes it more vulnerable. All right, so that was the heart. Then for the blood, we have either increased or decreased blood volume. As we decrease blood volume, we decrease pressure. As we increase blood volume, we increase pressure. And so the major determinants of that, the kidneys, under the influence of various hormones. And what were the two major hormones we talked about last time? Aldosterone and, well, there is ADH also, but natriuretic peptides. Yeah. And the main natriuretic peptide was B natriuretic peptide, which is produced by your ventricles when they are overly stretched. So maybe it'd be better to call it VNP, but hey, we call it BNP. All right, then we have the arteries themselves. And the arteries themselves can either constrict or dilate, depending on the situation. So what are the two biggest vasoconstrictors that we have in our bodies? Norepinephrine, epinephrine, which stimulate what receptors? Alpha-1. And then we have angiotensin 2, which causes vasoconstriction and the release of aldosterone. So you got to remember your renin, angiotensin, aldosterone cascade, which I'm not going to draw on the board at this moment in time. All right, and then there's other local things that influence it, such as nitric oxide.
We're going over diet or
What?
You mean,
Oh, and then as far as dilators go, the only one we really talked about was bradykinin and nitric oxide. All right. Any questions about the quick recap? No, that was worse. All right. So here's the thing. All we've done so far is just review anatomy and physiology 2. We haven't even gotten to the patho yet. So now it's time to get into some patho. Actually, no, we did a little bit of patho for high blood pressure. What we're going to talk about right now is we're going to talk about blood pressure drugs. So the first blood pressure drugs we're going to talk about are drugs that affect the renin-angiotensin-aldosterone pathway. So at this point, we're going to draw the renin-angiotensin-aldosterone pathway. So what does it start with? Angiotensinogen. And what produces that?
liver.
The liver, right. And then that's going to float around in your blood until it gets converted into angiotensin 1 by what enzyme? Renin. And what produces renin or secretes it? The kidney. So when the kidneys are perceiving, hey, we don't have enough blood flow, there's not enough blood pressure here, they secrete renin. That is going to convert angiotensinogen to angiotensin 1, and then angiotensin 1 is going to be converted into angiotensin 2 by an enzyme called ACE, angiotensin converting enzyme. And that enzyme is produced by which organ? It's another organ that starts with L.
Liver.
Not your liver. How many can we think of? How many organs are there that start with L? And is not lymph nodes? Not liver.
Lungs.
Lungs, right. So it's secreted by your lungs, and it's going to cause angiotensin 2. Now, we've already talked about the effects of angiotensin 2, which are primarily vasoconstriction, which is going to directly increase blood pressure, and then secretion of aldosterone, which will indirectly increase blood pressure. At the same time, ACE also breaks down bradykinin. What is bradykinin? It's a vasodilator. So when we inactivate it, we're going to decrease vasodilation. So that's a kind of a double effect on vasoconstriction. One by inhibiting vasodilation, the other by causing vasoconstriction directly. So how about if we have some drugs that impact that? What do you think? So the first drugs that impacted this are called ACE inhibitors. So they inhibit ACE. So they prevent the production of angiotensin 2. They directly lower blood pressure by inhibiting vasodilation, by inhibiting vasoconstriction, so they are considered vasodilators. Their effects can be very, very quick, so you got to be very careful, especially in elderly patients. They're notorious for causing first dose hypotension, particularly in the elderly. So this is one of those drugs where you start them at a low level and then increase the dose as needed. You don't want to start at a high dose. Hypotension. Yeah, they lower the blood pressure a lot on the first dose. So patients typically, it can have a dip and then they go back up kind of a little bit more. So you got to be careful with that dip. Elderly patients what can happen if their blood pressure goes too low? What would an elderly person be at risk for? Falls. So we've got to be very careful in elderly folks who get ACE inhibitors for the first time. Question?
So it's going to inhibit Ang2, which causes vasoconstriction.
Yes.
And that's what is it?
It's inhibiting the production of angiotensin 2.
Okay, then does it do anything to bradykinin when you inhibit it?
Yes, it will also cause bradykinin to not be broken down. So there'll be more bradykinin present, which will cause vasodilation.
So you will get vasodilation. Okay, never mind.
Yeah, so you're going to get vasodilation.
So everything after angio 2, it's going to inhibit them.
Yes, it's going to inhibit these two effects.
And then
and it's also going to inhibit this breakdown.
Okay.
So the net effect of that is we're going to have vasodilation, which will lower a patient's blood pressure. We've got to watch out for first dose hypotension, especially in elderly folks who are at risk for falls when that happens. So we're going to start them on a lower dose and then raise the dose as needed. The next thing that we have to think about with these drugs in terms of adverse effect, and this is the most common adverse effect, is a buildup of bradykinin in the lung. Why in the lung?
Because ACE is made.
Because ACE is made in the lungs. So you can get a buildup of bradykinin in the lung, which can cause a dry cough. It's just a very nagging, doesn't go away cough. Nothing helps it cough. If a patient has that, pretty much the only thing you can do is take them off the drug. The next big adverse effect to look for is angioedema. Angioedema is basically a type 1 allergic reaction. It's associated with the bradykinin buildup, but it's less common than cough. And if a person has it, it's potentially life-threatening because it is a type 1 allergic reaction. So if a patient has that, we're going to take them off the drug. And then the last adverse effect we're going to talk about is because of aldosterone, by inhibiting aldosterone, sorry, let's back up. What does aldosterone do in your kidney?
More NIK pumps
More sodium potassium pumps, which pumps potassium where?
into the water.
Not into the blood. Into the urine. So it's going to make potassium go down. When you inhibit that, because you're inhibiting aldosterone secretion, what will happen to potassium? It could potentially stay in the blood more, which has a potential to cause elevated potassium levels. Now, by itself, it's usually not that big a deal, but it can interact with other drugs that affect potassium. Does that make sense? Like yes, like tramtrine, like hydrochlorothiazide. So if you have a patient who is on, say, hydrochlorothiazide, and they need a potassium supplement, and now you put them on an ACE inhibitor, they might not need the supplement anymore. So you just have to monitor potassium. Does that make sense? Okay, so 4 big adverse effects. What were they?
Buildup of bradykinin in lung causing dry cough.
That was actually the second.
The first one.
It's the first high dose hypotension.
First dose hypotension,
Buildup of bradykinin.
cough,
Angioedema.
angioedema,
And then
elevated potassium, potentially, and interacts with other drugs that cause potassium. So those are the big things in terms of ACE inhibitors. Now, ACE inhibitors kind of revolutionized the treatment of blood pressure in a lot of ways because they have so many beneficial properties. They help preserve kidney function in diabetic patients. And they also help with the remodeling of the arteries and heart. Remember last time we talked about aldosterone, that one of the long-term effects of aldosterone is they cause an increase in smooth muscle cell proliferation. So by inhibiting the production of aldosterone, you help to prevent some of that, which can help in heart attacks and strokes. Remodeling of the heart and smooth muscle cells of the arteries.
So much.
I know. Yeah. So all of the ACE inhibitors end in pril. So you've got lisinopril, fosinopril, tandalopril, ramipril, quinapril, you name it, a pril. So if you see a pril, what is it? ACE inhibitor. Now, one of the older ACE inhibitors, for whatever reason, just kind of became the most popular, is lisinopril, and that's the one you guys are going to memorize. Yeah. But if you see any pril, what is it?
It's an ACE inhibitor.
It's an ACE inhibitor.
We have enalapril too.
Yeah, enalapril, the reason that's on there is that it can be given IV, and it's not that many are given IV, so sometimes you'll see that one IV.
So lisinopril is PL.
Yep. All right, so that is ACE inhibitors. Now, the next drug that we're going to talk about is called an angiotensin II receptor blocker. So the first one works here, second one works here. Angiotensin II receptor blockers directly inhibit the receptor AT1. So remember, there's more than one kind of receptor. We didn't really talk about angiotensin II receptors, but that type 2 receptors, but that's okay. They're in the notes in case you ever want to read about them. You're like, why would I want to do that? I can't even remember the first stuff. So angiotensin 1 receptors, again, are what's responsible for the vasoconstriction and the aldosterone release. So we're directly inhibiting those two things, but we are not inhibiting the production of angiotensin 2, and we are not inhibiting the breakdown of bradykinin. As a result, angiotensin receptor blockers do not have any cough.
We then confused. So you still make angiotensin 2. It just can't.
You're inhibiting the receptor that angiotensin 2 activates. So there's no cough. It still has the beneficial effects on the kidney when you have a patient with diabetes. So they can be used in a patient who's allergic to ACE inhibitors. You can put them on an ARB instead.
But would you always pick an ACE inhibitor first?
Not necessarily.
Okay.
So yeah, you wouldn't necessarily choose one first, although generally you probably would.
Okay.
And then there is still a risk of angioedema, although the chances are much, much lower.
Oh, right. So it still can help prevent nephropathy.
Yes, it still helps to reduce the risk of nephropathy in diabetic patients. So remember, every diabetic patient should be on an ACE inhibitor unless they're allergic, in which case they should take
Angiotensin 2.
an angiotensin receptor blocker instead. And what's the purpose?
Of them in the kidney.
What's the purpose of giving that to a patient with diabetes?
Reduce the nephropathy.
Reduce the risk of nephropathy. All right. All of these drugs end in sartan, losartan, irbesartan, candesartan, other sartan. I believe the drug you guys need to know for your test is losartan. But if you see any sartan, you should know that it's an angiotensin receptor blocker. Now, even though there's a lot of overlap in the way that ACE inhibitors and angiotensin receptor blockers work, if you give them together, you do get an increased effect of blood pressure lowering. However, there's some other risk factors that go up that make it potentially dangerous for a patient. So the recommendation used to be that you could give them together, but is now you would never give an ACE inhibitor and an angiotensin receptor blocker to the same patient at the same time. So they can have one or the other, but not both. All right. Next, we have some drugs that inhibit aldosterone directly. So we actually learned both of those earlier on, eplerenone and spironolactone. Now, spironolactone is not actually marketed as a blood pressure drug, although it can act as one very mildly. Eplerenone works the same way. It's an aldosterone receptor blocker, and it has more of a blood pressure effect. We're not actually calling it a potassium-sparing diuretic at all, even though that works the same mechanism as spironolactone. As far as major adverse effects goes, the major adverse effect we need to be careful about with eplerenone is potential for elevated potassium levels. All right, then we have drugs that inhibit renin. These are known as direct renin antagonists. They never really caught on, and so I'm going to skip them. I believe there's a slide in the voice thread about them, but they're not going to be on your test.
For the direct aldosterone inhibitors, so by inhibiting them, it just causes vasodilation.
Yep. All right. Any questions about renin, angiotensin, aldosterone drugs?
Spironolactone, can that cause high potassium?
Yes. But we actually talked about spironolactone in some detail, so I'm just basically saying, hey, go back and review that. All right. Any other questions about renin-angiotensin aldosterone drugs. All right, next we have calcium channel blockers. That is what's next on your notes, right? Is that a yes or a no? All right, so we got to review a little bit about calcium. So what do you remember about your A&P 1 muscular contraction lectures?
Sarco.
What? What's a sarcomere?
Yeah, that was the word
I couldn't even remember mirror, I just remembered sarc. Like sarcastic? Okay, so if you'll recall, there are thick filaments, and then there are thin filaments. So what are the thin filaments called? The thin filaments are actin, and the thick filaments are myosin. So, and then the myosin has these little contractile heads on them, right? And so they kind of reach up into the actin and then ratchet inwards, right? So there are little receptors where the myosin can bind to on the actin. Now, when we don't want the muscle to contract, that is, we want it to be relaxed, what we do is we have this winding protein that wraps around and blocks those receptors so myosin can't bind to it. What's that winding protein called? Right, tropomyosin. So tropomyosin is blocking the binding sites on the actin. So in order to allow the contraction to take place, we have to unwrap the tropomyosin. Now there's a receptor on the tropomyosin that when it's activated will do that. What's that receptor called? What is the receptor that causes the unwinding? It's called troponin. Now, so you can think of troponin as a lock and the tropomyosin as a door. So we need to open the door. How do we do that? We have to unlock it. What's the lock? Troponin. So now, what's the key? Say it again.
Calcium.
It's calcium. So calcium is the key. So when we don't want the cell to contract, what we do is we trap the calcium where? These little blue dots are calcium. Where do we trap the calcium? In the sarcoplasmic reticulum. Oh, sure, yeah, you say, yeah, I knew that, but you didn't know well enough to say it. Okay, so how do we get the calcium out of the sarcoplasmic reticulum to where it can activate the troponin? Well, what's the name of this drug that we're about to talk about? Calcium channel. There's calcium channel. Okay, so there's little calcium channels in here that are closed until there's a stimulus that says contract. So the muscle cell contracts and then the blood vessel constricts. So in order to contract, we have to send a signal to these calcium channels to open up that'll allow the calcium to diffuse out, and then it will activate the troponin, unwinding the tropomyosin and allowing the myosin heads to bind to the actin binding sites. Whew. So,
3 classes in A&P on that.
yeah, and we just did it in 5 minutes.
5 minutes.
So, the calcium channel blockers make it harder for calcium to get out. So the calcium doesn't come out as quickly, which in turn is going to reduce the contractility of those cells. Does that make sense? So, which cells are being inhibited? Well, they're muscle cells. But what kind of muscle cells? Smooth muscle cells. Kind of like smooth criminal. Now, where? In your arteries. So you're going to have it's going to cause vasodilation in the arteries, but it can also cause relaxation in other smooth muscle cells. So one of the potential adverse effects is constipation because it decreases peristalsis. Also, by causing vasodilation, it has the potential to cause edema in your peripheral vascular system, primarily in the feet. So patients with calcium channel blockers will sometimes get swollen feet.
Wait, why? Because they're not.
Because of the way the vasodilation occurs. Yeah. And then it can also, depending on the drug, cause decreased contractility and heart rate in patients who are in the heart. So certain drugs do not affect the heart at therapeutic levels, but they might if you go toxic. Other drugs can affect the heart at therapeutic levels. So the two big divisions among the calcium channel blockers are the dihydropyridines, and the non-dipines. So, dihydropyridines and non-dipines. The dihydropyridines, artery only. They can still cause constipation, but they don't affect the heart, is what I'm saying. So arteries, but not heart. The non-dipines can affect artery and heart. Does that make sense? Mm-hmm. All right. Now, a couple uses for these drugs. The first one and the main one is for blood pressure. By causing vasodilation, you decrease blood pressure. They can also be used for what's called vasospastic angina. Or angina. Angina or angina is chest pain, typically associated with decreased blood flow to the heart. One of the potential reasons for that decreased blood flow is a muscle spasm of the coronary artery. That's called vasospastic angina. It's also called Prinzmetal, but we'll talk about that in another lecture. By relaxing the coronary arteries, you can increase blood flow to the heart. So you can use it as a treatment for that kind of angina. Does that make sense? Okay. And then, with the ones that affect the heart, you can also use them to reduce the contractility of the heart. And they will also reduce the electrical conductivity of the heart, but we're not going to talk about that until we do dysrhythmias later on. But just be aware that they can do that too.
Decrease.
So they decrease contractility, heart rate, and conductivity. But there's a compensatory effect. When you cause decreased contraction, your heart will respond with sympathetic response. Your body will respond with sympathetic response, which will effectively raise the heart rate. So even though you've got a drug trying to lower heart rate, you've got increased heart rate as a reflex, which kind of cancels it out. So the net effect of the non-dipines on the heart is just decreased contractility and decreased conductivity, but neutral heart rate. Does that make sense? Mm-hmm. All right. Now, if you're giving a drug that can decrease contractility, what potential adverse effect do you think it could have? What's it called when your heart loses so much contractility that it can't pump blood adequately? I'm sorry. I thought you were just yawning. Did you mouth the words? Use your voice. Well, it's 2 words.
Atrial fibrillation.
Not atrial fibrillation. Heart failure. So calcium channel blockers can result in heart failure. Now, that means that anytime you put a patient on a calcium channel blocker, you need to be looking for signs and symptoms of heart failure. And you can just say that right now and then put asterisks. Wait till we get to the heart failure lecture. And then you can go back and fill that in. So on your test, wait a minute, there's going to be a test? On your test, you might have a question that asks you, what should you assess in a patient receiving a drug like this? And the answer would be, look for signs and symptoms of heart failure. So, adverse effects of calcium channel blockers. Because of their vasodilation effect, they're going to lower blood pressure, so they can have low blood pressure. It can also cause decreased contractility in the GI tract, so constipation. It can also cause increased dilation in the capillaries, so that can cause problems with ankle edema. It can also cause a little bit of proteinuria as well. And then, within the heart, we have the potential for heart failure. Okay, so, and I guess now we should learn some drug names. So, the drug name we're going to learn right now, the most common one for a long, long time was amlodipine, which is better known as Norvasc. At one time, it was the #1 prescribed antihypertensive drug in the United States. There are a number of others, felodipine and some other dipines. They all end in dipine, nifedipine, felodipine, and there's another one, dipine, that we use in the ICU for patients with a with hypertensive crisis, and I'm drawing a blank on its name at the moment. So, calcium channel blockers, dipines, what do they do?
Vasodilation.
Vasodilation, only at therapeutic levels. Then the non-dipines, we've got diltiazem, and verapamil. And these drugs can affect both arteries and the heart. So they can cause vasodilation as well as decreased contractility and decreased conductivity. Any questions?
Can you repeat what they do again?
What do?
The two drugs. You said the three.
So diltiazem and verapamil can affect both the arteries and the heart. So they can cause vasodilation, lowering blood pressure, and they can also cause decreased contractility and decreased conductivity in the heart. Any questions? One more time with feeling. Okay, question? No? You're just saying yes one more time with feeling? Okay. All right, what do we have next on our list of lovely drugs? What do you have? By the way, I guess the union workers end at 3:30 because no more vibrations. No, you're supposed to look at your notes, not the list.
Oh, hold on.
Say again? Adrenergic blockers. So beta blockers and alpha 1 blockers. This is a review from Pathopharm 1, so we're going to go super fast. I expect you to just, remember all that stuff, and I guess you could review it if needed. So beta blockers. We can block beta 1 and beta 2, but in the heart, the effects are exclusively beta 1. Causes a decrease in heart rate, contractility, and conductivity. So the way that they work for blood pressure is by reducing cardiac output through decreased heart rate and decreased contractility. They have the potential to cause heart failure, but they can also be used to treat heart failure, and we'll talk more about that when we get to heart failure. They can also be used in patients with MI, and we'll talk about that when we get to patients with MI. They can also be used to treat patients with angina pectoris or chest pain, and we'll talk about that when we get to there. Whew, we got a lot about that. As far as giving beta blockers, what's the most important thing to assess before giving a beta blocker?
No.
Are you sure it's respirations?
No, it's the heart rate.
It's the heart rate. And what's the way you're going to take their heart rate?
Apical.
Apical pulse. If you want to take an apical pulse, that's fine by me too. So, how do you do apical pulse? So, fifth intercostal space, midclavicular line. And what are you going to do?
For a full minute.
What are you going to do for a full minute?
Just listen to it.
You're going to listen?
Tape.
I'm listening.
Take your stethoscope.
What am I doing while I listen?
You're counting.
Count! Yes, count is the key word. You'd be surprised how I listen. What are you doing while you listen? Listening? So you got to count the number of beats in 1 minute. If that number is less than what?
60.
Are you sure about that?
30.
50. If the number is less than 50, you're going to hold the next dose. So even though less than 60 is considered bradycardia, we're not going to hold it until they get down to 50. Okay, this is really important. Remember, we talked about in Pathopharm 1 that these drugs were originally developed as blood pressure drugs, but now they're mostly not used for blood pressure. They're mostly used for things like heart failure and dysrhythmia and heart attack patients. So if you hold their beta blocker just because they have kind of like a normalish blood pressure, you can end up having the patient get a coronary event later on in the day, and that would be bad. So the only reason you're going to hold it is heart rate less than 50. If you hold it, you're going to call the doctor and let them know. As far as adverse effects go, we talked about heart failure, we talked about low blood sugar, or low blood pressure, low heart rate. A lot of patients will have fatigue. Some patients, especially when they first start taking them, some patients are like, I don't even have energy to get out of bed. They can cause decreased libido and erectile dysfunction.
You spoke too soon. With the union workers.
Yeah,
So- Yeah, I know. Maybe they just took a break, smoke break. When it comes to beta blockers, they can also cause loss of the sympathetic response that is associated with early stages of hypoglycemia, so diabetic patients should take them with caution. And then we have the distinction of type of selective versus non-selective. The two types of patients who should not take non-selective beta blockers: COPD patients and asthma patients, because it can interfere with their beta adrenergic treatments, their beta 2 agonists. And then diabetic patients, because it can interfere with the compensatory mechanisms for hypoglycemia. I told you you're going to be fast.
The drugs for non-selective are carvedilol.
So the non-selective drugs that we learned were carvedilol and propranolol. The selective drugs that we learned are metoprolol and atenolol. Now, the vast majority of beta blocker you're going to see out there is most likely going to be metoprolol. All right, alpha-1 blockers. Alpha-1 blockers cause vasodilation, but they're not very good for lowering blood pressure because there's one study that just showed that it just wasn't as good as the other drugs. So you're very rarely going to see them used for blood pressure, although they can be used for it. The number one adverse effect is going to be low blood pressure, and especially orthostatic hypotension. So you might be okay until you stand up, and then all of a sudden your blood pressure drops and you get risk for falls. So to prevent that, one, we tell patients take the drug at night, so hopefully they're sleeping when it's the highest risk of orthostatic hypotension. And then two, we are going to tell them to dangle their legs on the side of the bed for 5 to 10 minutes before they get up out of bed. Takes a bit of planning. You can't just get up and go. You got to get up and wait. They can also cause erectile dysfunction, and they can inhibit ejaculation. The major use of alpha-1 blockers, we said, was in BPH. So most of the time when you see it, it's going to be used for that purpose. If you see it in a female patient, then it's not being used for BPH. All right, any questions about adrenergic blockers? What's next on our little list of items?
Is it benign prostatic?
Benign prostatic
Hyperplasia.
hyperplasia. All right, any other questions about adrenergic receptor blockers? All right, next, what do we have?
Vasodilators.
Direct vasodilators. So we have a couple of these. First one is nitric oxide, which we mentioned is an older drug that is used for hypertensive crisis. It causes dilation of both arteries and veins. Then we have organic nitrates, such as nitric oxide is used for hypertensive crisis. Then we have organic nitrates, which can include nitroglycerin, NTG for short, and then isosorbide, mononitrate, and dinitrate. And these are just other longer acting forms of nitroglycerin, essentially. So nitroglycerin is a vasodilator, and it can dilate both veins and arteries, and it'll lower blood pressure. The major use for nitroglycerin, however, is not so much to lower blood pressure as it is to treat chest pain. So we're really just going to talk about the nitroglycerins more when we get to the chest pain part. So just mentioning that they can be used for blood pressure here, and we're going to move on. Any questions on that? The building is about to shake apart. I feel like Beavis. Have you guys ever watched Beavis and Butthead?
Yeah.
So I feel like right about now. All right. Now I forgot. Oh, so there's a very old drug called hydralazine that you may occasionally see. It's a vasodilator and can be used for blood pressure and heart failure. All right, next.
What was it used for?
Blood pressure.
Blood pressure and heart failure. Oh, sorry. When we were talking about the adrenergic antagonists, I should also mention clonidine. So clonidine works by activating alpha-2 receptors in the central nervous system, which in turn decreases the amount of norepinephrine being released, thereby lowering blood pressure. All right, let's move on.
Which part was it for clonidine? Where is it located?
Clonidine, okay, so clonidine is an indirect sympathetic antagonist. It activates alpha-2 receptors in the central nervous system, which in turn inhibits the amount of norepinephrine being released, which in turn lowers blood pressure.
What's the name of the alpha-1 blocker?
The name of the alpha-1 blocker, tamsulosin, but
Another one, right?
terazosin and phentolamine. Yeah. So phentolamine, anyway, who cares? Let's move along. You can re-listen to Pathopharm 1 on your own.
Joy.
Yeah, most of the alpha-1 blockers are not used for high blood pressure, so there's no point in naming them at this point. Okay. I feel like I'm missing something. What am I missing? Yeah, we're going to talk about that when we get to chest pain. All right.
Reading from the drug list.
Yeah, I think that's it for now. So let's be done.
Oh, thank God.
Yeah, I think our brains are a little too rattled to continue at this time.
Any chance